Okay, everyone, for injuries for Lab 9 elbow, I think what I'll do is I'll just talk through them as I would normally, and then if there's any additional information that I need to add, then we'll write that down. So our first injury, olecranon bursitis. So this is an acute traumatic injury. Usually there's a fall directly on the elbow, or sometimes more minor falls, even repeated leaning on the elbow, for example, if you're studying for long periods of time. And we get either buildup of irritation of the bursa, so right over top of the olecranon process, there's a bursa there that's underneath the triceps tendon, and that bursa can get irritated. So as it gets irritated, it swells up, and the athlete's going to have pain with elbow flexion and extension. They might have a little bit of weakness with resisted elbow flexion and extension as well, because there's going to be pressure over top of the bursa. If we palpate over the bursa, that will be sore. It might feel a little bit soft or squishy, and we may see some visible swelling. With a significant impact, we can even rupture the olecranon bursa, and in that case, it's very easily infected, and the whole arm can swell up quite dramatically. That lacrosse video that I showed you where I was hit and injured my shoulder, in the same series, one of my teammates fell on his elbow, ruptured his olecranon bursa, became infected, and he was removed from the rest of the series. He had to be on IV antibiotics for the rest of the week. So our treatment for olecranon bursitis is pili or pili. We don't want to add any further compression over there. Minimize range of motion to keep it from getting irritated. With our mild bursitis, athletes can still play through this. We just want to make sure that it's padded, that they're not going to fall on that area again and further the irritation. And for our significant impacts, if they've been off with IV antibiotics, then our gradual reintroduction to sport to make sure it's not going to irritate the bursa again. For our lateral epicondylalgia, this is a chronic gradual onset injury, usually associated with repetitive wrist extensions. Remember, our wrist extensors originate at the lateral epicondyle, the common extensor origin. So racket sports especially, and that's why it's called tennis elbow, because those repeated backhands in tennis can aggravate the wrist extensors at the origin. Also, if we're forcefully gripping something, you think, well, how is that going to affect the wrist extensors? But as hard as we grip with our wrist and finger flexors, our wrist extensors have to counteract that force to keep the wrist in neutral position. If we didn't do that, then our wrist would just flop down into flexion each time we tried to grip something. And in particular, extensor carpi radialis brevis is always involved with gripping objects, and is always involved with lateral epicondylalgia as well. So in terms of our assessments, we might see some redness or signs of irritation at the lateral epicondyle. For range of motion, elbow flexion extension usually is pretty good. They might have some discomfort at the end range of elbow flexion, just because it's going to put a bit of stretch through the wrist extenders. Active range of motion, they may have some discomfort at the end range of wrist flexion because it's going to stretch out those wrist extensors. They might have some discomfort with active wrist extension. For strength, they're going to have some weakness and pain with wrist extension and even finger extension. When we do our grip strength They'll have some weakness and pain with that. Our wrist extensor stretch test that you learned in lab from the video will be positive. And the TOP in your lab note stands for tenderness on palpation over the CEO, the common extensor origin of the lateral epicondyle. So when we palpate the lateral epicondyle, it will be sore. In your lab notes, it mentions correct shoulder biomechanics for treatment. So this is another injury where we would do our scapulohumeral rhythm, and I'll include that there, scapulohumeral rhythm. Because if there's anything going on biomechanically with the shoulder, it's going to get passed down the kinetic chain down through the elbow into the wrist and hands even. So you'll do your scapulohumeral rhythm. If you notice anything like some scapular winging, then you've got to address that as part of your treatments. We're also going to work to try and stretch our wrist extensors, so maybe some self-massage, gentle stretching. For strengthening, we'll begin with isometric, and then moving on to concentric, and then eccentric. So isometric, remember the muscle is contracting but not moving. So we can just push our left hand down on top of the back of our right hand, and our right wrist extensors will be contracting to prevent the wrist from going into flexion. For concentric, just our regular wrist extension exercise, and then eccentric loading. This is another key part of rehab, or another injury where eccentric loading is key for the rehab of that injury. So to do eccentric loading for our wrist extensors, you get a forearm resting on the table, holding onto a small weight, 1 or 2 pounds usually, and you'll use the non-injured side. So if my right elbow, lateral elbow, has the lateral epicondylalgia, my right forearm be resting on the table, forearm pronated, so palm facing down, holding onto the small weight, and I use my left non-injured side to help the wrist up into extension, and I slowly lower the wrist down into flexion. I help my wrist back up into extension, and I slowly lower it down into flexion. So as the wrist is lowering down in flexion, the wrist extensors are contracted, but they're lengthening at the same time. So that's a eccentric contraction for those muscles. Compression bands, or tennis elbow strap, so it wraps around the proximal forearm and squeezes or compresses. And the idea is that it's going to wrap tightly around the muscles so that there's less pull of those extensors through the lateral epicondyle or common extensor origin. We will talk in lecture 11 how research doesn't necessarily support the theory of tennis elbow strap, but many people do get symptomatic relief from it, so we still use it. Medial epicondylalgia, or golfer's elbow, so repetitive use of our wrist flexors, and we get irritation at the common flexor origin or the medial epicondyle. It's called golfer's elbow because that's one sport where it can be associated with, but really any activity where we do repetitive wrist flexion can aggravate it. So in this case, we're going to have maybe some redness, irritation at the medial epicondyle. We're going to have, for range of motion, perhaps a little bit discomfort with active wrist flexion, and then some pain with active wrist extension because they're stretching out their wrist flexors. For strength testing, they may have some weakness and pain with resisted wrist flexion, and when we do grip strength as well, to be painful at the medial epicondyle. And if we palpate over the medial epicondyle, that will be sore. Treatment is essentially the same as it is for our lateral epicondylalgia. It's just in this case we're focusing more on the wrist flexors rather than the wrist extensors. So stretching out the wrist flexors, strengthening isometrically, isotonically, and eccentrically. So in this case, the eccentric loading, if the right medial elbow has the epicondylalgia, I'll be resting my right forearm on the table, holding onto a small weight, but palm facing up now, or forearm in a supinated position, and I let the wrist lower down gently into extension. I use my right hand to help it back up, my left hand to help the right wrist back up into flexion, and I slowly lower it back down into extension. Use the left hand to help the right back up in the flexion, and I slowly lower it down into extension. We can use the same compression strap, our tennis elbow strap. We can use it for medial epicondylalgia. You just rotate the strap around so it puts pressure on the wrist flexors rather than the wrist extensors. And then lastly, our collateral ligament sprain. So we can sprain either our medial or collateral ligaments at the elbow. It's just they're more commonly known as the ulnar collateral ligaments on the medial side and the radial collateral ligament on the lateral side. The ulnar collateral ligament is the one is much more commonly injured. And usually in tackle sports, if you're grabbing onto somebody, if your arm gets pulled back into a valgus position, you're going to perhaps stretch and or tear that ulnar collateral ligament. So there's going to be pain on the medial side of the elbow, perhaps some swelling. Range of motion may be decreased both into flexion and extension because of pain. And when we do our ligament stress tests for the ulnar collateral ligament, there'll be increased laxity and pain. And if we did our varus stress tests for the lateral collateral ligament, if we thought that was injured, there might be increased laxity or pain with that. Treatment, police, rest, maybe even a sling if it's very painful. And then we'll start working on range of motion, flexion, extension, strengthening, isometric, isotonic, eccentric. And we'll increase loading or activity through the elbow. If it's an athlete that needs to throw, then we'll increase the number of throws, the distance, and the velocity that they're throwing at. Now our ulnar collateral ligament sprain for baseball players, particularly for pitchers, long ago it used to be a career-ending injury. But for 45 years now, they've been doing a surgery called Tommy John surgery, and it's named after the first pitcher that they did it on. And what they do is they take a tendon, our palmaris longus tendon, so that tendon that about 30% of us no longer have. They'll take that tendon from the forearm and they'll fashion a new ulnar collateral ligament out of it. The surgery is quite successful, actually. Many pitchers return. They quite oftentimes come back close to the pitching velocity that they had before. A few have even exceeded the pitching velocity that they had before the surgery. And it's not that the surgery has made their arm super strong, it's all the rehab exercises that they've done to strengthen the whole arm has helped. There's some controversy because some high school pitchers are opting to have the surgery done even without a ulnar collateral ligament sprain or tear, because they know if they continue on with pitching that there's a high likelihood they might need it down the road. So they opt to have the surgery done in their teen years rather than miss years of pitching potentially in the major leagues when they're could be making millions of dollars. So again, some controversy around the parents that are allowing the athletes to have this surgery done even if they don't have the injury. The rates of rotator cuff tears in Major League Baseball pitchers has decreased significantly in the last 10 to 15 years. And that's largely attributed to pitchers taking on a bit more of a sidearm delivery, which puts less stress on the rotator cuff tendons, but it puts way more stress on the ulnar collateral ligaments at the elbow. And so we've seen a significant increase in the number of ulnar collateral ligament sprains and tears in baseball. So that's the injuries for the elbow lab. So you can review those. If there's any questions, you can send